we're moving on more into the more clinical application of some of these concepts. And I'm very pleased to introduce my co-chairman, Angelos Halaris, who's going to talk about pharmacological and non-pharmacological interventions to arrest neuroprogression.
Okay, we know these illnesses are chronic, progressive, relapsing, treatment-resistant, and on and on and on. The progressive nature and recurrent nature of these illnesses doesn't bode well, not just because these patients become increasingly dysfunctional, but also because the brain is compromised, their life expectancy is shortened, there is higher comorbidity with all sorts of other non-psychiatric conditions, and functionally they're debilitated and increasingly so over the course of their illness. So that begs the question, what can we do? Can we do anything to not cure these illnesses? We cannot do this at this point, but can we at least do two things? A, diagnose early. Point one, diagnose accurately. B, choose the right treatment. Decide how long treatment should be administered, and in so doing, in accomplishing these very lofty goals, which we're not meeting at this point in time, arrest, if not reverse, the neuroprogressive course and nature of psychiatric illnesses. So this is what I'm going to talk to you about today. You've heard a lot about the immune system. I don't think this should come as a surprise to anybody in this audience. Stress is the major, what I call the major instigator or major primary nominator in a cascade of events that you see here depicted, including changes in monoaminergic systems, but catecholamines, glucocorticoids, excitatory amino acids. But I want to jump the gun a bit and focus on cyclooxygenase. This is an enzyme that is very critical. It is inhibited by medications that are available in all countries of the world, known as cyclooxygenase inhibitors, the classic one being aspirin. It's a mixed COX-1 and COX-2 inhibitor, and we have other ones. I think celecoxib is known worldwide. Arcoxia is another one that's available in most countries except for the United States and possibly Canada. So today I'm going to focus my presentation on COX-2 and its inhibition. Preempting the talk, it would be too good to be true if tweaking COX-2 activity would come without any potential downsides. There are potential downsides. I'm sure you've heard a lot of talk about cardiovascular side effects, especially with chronic use, especially with higher doses. A lot of that has been hype. The good news is that based a very extensive study Pfizer conducted over the past several years to the tune of many millions of dollars, the safety of celecoxib as a classic COX-2 inhibitor is equivalent to the safety of other non-steroidal anti-inflammatories, such as even Tylenol is worse than celecoxib. So this is briefly what we're talking about today. We've heard yesterday, those who were at the meeting yesterday, you heard from my co-author, Dr. Bufido, who's in the audience today, a lot about PGE and PGE2 and PGE2 receptor. There is a close relationship between COX-2 and PGE2. In the interest of time, I cannot really delve too much into detail. Suffice it to say that there is a high connection between the immune system and COX-2. Okay, that's maybe all we can talk about today. The potential utility of non-steroidal anti-inflammatories in depression is not something that I can claim fame for myself. There have been very interesting studies published going back to several years ago, including studies from Germany, from the University of Munich, Norbert Müller, as well as Iran, under the leadership of Professor Akhondzadeh, and other studies in Belgium and Canada, Galecki being another one who has done excellent work looking at COX-2 inhibition in PGE2. This is a summary from the chapter that Dr. Bufido and I have co-authored that appears in the monograph I mentioned to you earlier. This is pretty much a summary of available data in the literature looking at clinical trials of COX-2 inhibitors and aspirin in schizophrenia. As you see, there are enough studies, but not an overwhelming amount of research. For the most part, these studies show a positive effect of COX-2 inhibition as far as symptom improvement and therapeutic efficacy in conjunction with a primary agent, whether it's an antipsychotic in psychotic disorders and schizophrenia, or an antidepressant in studies of depression. And here you see the equivalent studies in major depressive disorder, affective disorders in general. Again, there is about half a dozen of studies, and that's all we have to date. Not all studies agree, but the majority of studies, whether it's schizophrenia or affective disorders, converge on the final outcome. Yes, inhibition of COX-2 is beneficial. Now, I'm going to talk to you about a study I completed recently. This study focused on treatment-resistant bipolar depression. Okay, let me say at the beginning, bipolar depression, in my view, is not the same as unipolar depression. There are huge differences. I don't have time to go into those. Those amongst you who are clinicians will probably relate to what I'm saying. It's a tough disease to treat and manage, both acutely and chronically, with recurrences and relapses and some kind of treatment resistance that evolves during the course of treatment, where we have to go back and start from square one. Our hypothesis was that in partially treatment-resistant bipolar depressed patients who, according to Dr. Burke's staging, the first slide that, Michael, you showed, my patients, there was about 65 patients enrolled, 47 to 50 patients had completed data that we used for our analyses. They would all rank as stage 3 and stage 4, with at least partial treatment resistance or complete treatment resistance. So these patients were studied initially to make sure that it met criteria. The criteria was very, very strict. I don't have time to present all the criteria to you this morning. If they were not on adequate mood stabilization, because we didn't want to induce hypomania and thereby mislead ourselves into believing that we were seeing a miraculous effect, so they all had to be stabilized on either a mood stabilizer, except for lithium, because of an interaction between lithium and celecoxib, or an atypical antipsychotic. So these patients had usually valproic acid mood stabilization, or lamotrigine, which in my view works very well if you dose it carefully, and atypical antipsychotics, or a combination thereof. After that criteria was met, they underwent a 1-week placebo run-in on a single blind basis. The reason for that was so that we could weed out placebo responders. Out of about 65 total enrolled patients, we had about 4 placebo responders, and they were withdrawn from the study. Following that, they underwent the baseline determinations that included a multitude of rating scales, self-rating scales, and biomarkers for inflammation, the kynurenine pathway, growth factors, and a host of other variables that I described in my talk yesterday, such as heart rate variability. Then celecoxib was introduced on a double-blind, randomized basis, along with escitalopram. Escitalopram was administered as a steady SSRI at a dose not to exceed 20 milligrams per day. Celecoxib was given twice a day at a dose of 200 milligrams twice a day, again, on a double-blind randomized controlled basis. So this is, in essence, the study design. I just explained it for you. These are the demographics. How am I doing time-wise? 7 minutes. 7 minutes? Okay. All right, I'm not going to belabor the point here. We also had a control group of healthy subjects, total of 35 bipolar depressed patients with usable data for analysis purposes, 47 out of total number of 65 enrolled. This was the flow diagram of, we started out with 100 total, we ended up with usable data from 47 patients. We used the Maudsley scale to classify them for treatment resistance. And I don't know if any of you know what the Maudsley scale looks like, but in essence, the worst treatment resistance is 13, 14. Our patients were in the middle. The majority of them were sort of medium to moderately treatment resistant. Some of them had failed. They had to have failed at least one full adequate trial. The majority of our patients in this study had failed 3 to 4 trials. As I said earlier, they were allowed to use concomitant medications, mostly for mood stabilization, such as stabilizers other than lithium or antipsychotics. And here are the data. Patients who received the placebo plus escitalopram versus patients who received the escitalopram plus celecoxib. You can see here the response rate between the two arms of the study. You can see the non-response rate far greater on placebo than celecoxib. That was significant at a p of 0.02. Then we looked at those who had full remission, remission being defined as an end of study Hamilton 17 depression score of less than 7. So using this remission criteria, only 10% of the patients who received escitalopram placebo combination versus 63% of those who received the active combination. And that was impressively significant, that difference. Okay, we looked at the time course here, and we looked at the baseline. The two cohorts at baseline did not differ significantly with respect to depression severity. By week 4, they began to separate, with the celecoxib group having a lower depression score by week 4 compared to the placebo arm, and by week 8, by far the celecoxib group was much, much better off at a significant statistical value. Now, if we track the time course between the two arms, you can see clearly that those overall on the placebo escitalopram do respond, but at the end of the treatment phase, which was 8 weeks long, we still have a significant separation between the two arms. That's the same thing that I showed you in the diagram earlier. Another hypothesis, an ancillary hypothesis, was that we would see an earlier, not just an augmented response with celecoxib combination, but also an earlier onset of the antidepressant effect. So I had the foresight, perhaps on an intuition basis, to assess the patients also at week 1, 2, 4, and 8. And much to my pleasant surprise, this is what happens at week 1. See the difference in the HAM-D17 score at week 1. Mighty impressive. So that hypothesis was confirmed. Anxiety, Hamilton anxiety. Does anxiety, which is very prominent in bipolar depression, lo and behold, again, that's at week 1. Both anxiety and depression improved significantly at week 1 in the combination group. Turning to inflammation, yes, bipolar depression has convincingly elevated pro-inflammatory cytokines. Not everybody, but the majority. So you can see here key pro-inflammatory cytokines, IL-2, 4, 8, TNF-alpha, interleukin-1 beta. They are all significantly elevated as compared to the healthy control group. What happens now? We looked at interleukin-1 beta. Don't have time to justify why interleukin-1 beta. Those of you who work in inflammation will understand why IL-1 beta is a very critical pro-inflammatory cytokine. We see a trend for a change between baseline and week 1 in the CBX celecoxib combination group, whereas in the placebo group, no change. So celecoxib also trends to reduce interleukin-1 beta. I submit if I had extended the study for another 4 weeks, we would have reached statistical significance here. This summarizes interleukin-1 beta biomarker levels and controls and the 2 treatment arms. And you can see here basically what I just finished telling you, that we do see at least a trend with possible significance down the road. Another beloved biomarker is CRP. Again, I don't need to explain to this audience why CRP is important to measure. And here we saw basically a very interesting phenomenon at week 8, CRP significantly lower at an impressive p-value as compared to the treatment arm that did not receive celecoxib. These are the HAM-D scores versus CRP. No significant, the p-value here is 0.02, not so here in the group that did not receive the celecoxib. And so to conclude, the analysis reveals that scores on scales of depression and anxiety showed a significant, and perceived stress, by the way, which I didn't have time to show you any data. All of these key scales show significant effects as early as week 1. Perceived stress, not quite at week 1, but anxiety and depression, yes. Perceived stress by week 8 was significantly lower, the score, in the celecoxib combination group. So we also looked at pain perception to make sure that because celecoxib also controls pain, and a lot of depressed patients have a pain perception, basically no effect on pain perception at all in either group. So we conclude here that modulation of inflammation by means of COX-2 inhibition converts treatment resistance to response and even remission as compared to the group that does not receive the COX-2 inhibitor. And with that, I thank you for your attention.
Thank you very much indeed, Angelos. There's raised a lot of questions, which I'm sure we're going to get from the audience, but you're not going to have much time. So please ask questions, make them short, and please answer them shortly.
Okay.
Yes, at the very back, please.
Given the talk we've just heard before yours, where it was quite convincingly shown that lithium is superior to all other prophylactics. Now, in your study, they could take any other mood stabilizer. Does the benefit of celecoxib outweigh the disadvantage that you can't use lithium in those patients?
Right, you cannot use lithium in combination with celecoxib because of an adverse drug-drug interaction. That was the only reason we didn't use lithium.
Yeah. Was baseline CRP a predictor of response?
Good question. It trended to be a predictor of response. No.
Please.
Is there any hope for an RCT of the best? We have olanzapine and fluoxetine with celecoxib, because fluoxetine is different from all other antidepressants because it influences DAG as lithium, and DAG goes to a cofactor, which is a cofactor of c-KIT, which is the main receptor of mast cells. And I would support mast cells as the actors because it's the only cells we have photos where they kill other cells.
Good point. Okay, I guess we're out of time as far
Yeah,
as...
we are. That's an interesting point. There are studies with celecoxib and fluoxetine, I think,
Yes, there are.
which were positive studies, and that's the Iranian group, if I remember correctly.
That's absolutely correct. That the
Yes.
Akonzada group that used fluoxetine,
Yes.
celecoxib, and came up with similar findings.
Yeah, yeah,
Yep.
yeah. Anyway, thank you for your questions. Angelos, you must sit down. Thank you very much
Okay.
indeed.